how do you recommend that general internists think about ILD and the different buckets? Because there's a whole alphabet soup that you go to fellowship to understand, and then when you come out of fellowship, you're still learning it. So what would be useful for the general internist to know when it comes to differentiating ILD?
Nowadays, when I lecture on ILD and I teach the fellows about ILD, I spend very little time on the alphabet. Whether you're talking about this is NSIP or COP or UIP or LIP or RBILD, that's the soup that we're talking about. The only way to get there truly is with a surgical lung biopsy. And that's the only definitive way to know for sure what the alphabet soup is. Now, we may look at a CAT scan and say, this is a pattern that looks like a UIP pattern. And if we can't figure out why it's a UIP pattern, therefore it's idiopathic and we call it IPF. Or maybe the CT pattern and the history, it seems like this could be an NSIP pattern. But unless you do a biopsy, you actually don't know, right? What's more important are broad categories of approaching the patient and figuring out what general category are we dealing with? Because more often than not, that is what drives therapy and patient action and physician action. And that's what's clinically relevant. So for example, your new ILD patient, the way you really need to be thinking about this is, one, is this an infection mimicking an interstitial process, right? So is this an immunocompromised patient on high doses of mycophenolate because of their renal transplant, and this is actually a CMV pneumonitis. This is not ground glass from an NSIP, right? So you rule out infection. And then you think about exposures, right? Is there something in the environment? Are we dealing with a hypersensitivity pneumonitis, right? Do they have birds? Do they have down products? Is there mold? Are they working in some kind of industry or something that's going to cause an inflammatory process or an autoimmune process because of something they're exposed to? Keeping in mind that even if you did a biopsy, you could see different parts of the alphabet soup, right? You can see a UIP, NSIP, organized pneumonia pattern with hypersensitivity pneumonitis. So there, the alphabet soup's not as helpful, right? It's what's causing it. You think about autoimmune processes, right? You take a really good history, you do a really good exam. Is there Raynaud's? Is there weakness? You get your serologic panel and your family history and all these other things that might lead you to think that there's something going on here from a lupus or a dermatomyositis or a scleroderma spectrum or a rheumatoid arthritis, et cetera. Do we need rheumatology involved? There again, we've published this ourselves with dermatomyositis or scleroderma or RA. What can you see on biopsy? The whole spectrum of the alphabet soup. You can see UIP, NSIP, organized pneumonia, LIP, right? So there again, if you went straight for the biopsy in the alphabet soup, it still wouldn't tell you the cause. And then idiopathic stuff, if you've done the full workup, you can still have the full idiopathic alphabet soup. So I think the soup really should be the dessert, right? Like it should be the last thing you think about. And we oftentimes don't get it. And patients say, what do I have? I say, well, you have an autoimmune form of interstitial lung disease. And sometimes you don't get specific and you don't have to, because the treatment might be the same, depending if it's autoimmune or inflammatory. I don't care what the pattern is necessarily. You're going to get your mycophenolate. And if it's predominantly fibrotic and there's not an autoimmune component, studies have shown that we're probably going to want to use an anti-fibrotic agent to stop the fibrotic component, right? Regardless of the cause. And we treat the autoimmune component sometimes regardless of the cause. We don't always need to know. And we can cause a lot of harm pursuing knowledge without changing how we approach patients.
That was amazing. I'm wondering too, if you could just detail out those buckets for me. There was, I think, 4 buckets that you gave. If you could just name those.
Yeah. So the main sort of buckets under the umbrella that we think about when we're going through for the ILD algorithm in general include infections. So there are infections that can mimic interstitial processes. And then we think about exposures. So environmental exposures, both organic and inorganic. We think about medications. So there are medication exposures that are notorious for causing interstitial processes. We think about autoimmunity. So all the rheumatologic diseases. So almost every connective tissue disease causes interstitial lung disease with some very rare exceptions. And then you have your sort of syndromes and idiopathic things. I would lump sarcoid there, amyloidosis, Langerhans as your own little entities, and then all the idiopathic interstitial lung diseases, your idiopathic NSIP, your cryptogenic organized pneumonia, and your idiopathic pulmonary fibrosis, recognizing that you really have to do your diligence before you get to put the idiopathic before it in case you miss something.
And then you were starting to get into the reason why buckets matter rather than the granularity is because it drives treatment. And you mentioned that for rheumatologic in general, they get cell-sept. And then for your idiopathic bucket, I know the studies for IPF show that immunosuppression was not helpful and in fact harmful. So it's really just antifibrotics for them. But does everyone in the idiopathic bucket, idiopathic NSIP, do you think of that the same way? I know there's not much literature out there.
Yeah, so I think there are nuances, right? And even within rheumatologic, somebody who has rheumatoid arthritis ILD, we might think about different types of immunosuppression versus somebody who has myositis ILD, depending on some of the extrapulmonary issues we're trying to treat, because like cell-sept is terrible for the joints, right? It doesn't treat joint disease. And our RA patients often have more joint involvement than, let's say, our myositis patients, et cetera. And so there are nuances within these buckets. Within idiopathic pulmonary fibrosis is a pure fibrotic process. And so we know, as you said, that immunosuppression is not only unhelpful, but harmful in those patients. We had many studies showing that, predominantly the Panther trial. But idiopathic NSIP is not solely a fibrotic process, right? So there can be inflammation there, especially if there is the cellular. And some of those patients may benefit from the use of immunosuppression. So idiopathic by itself doesn't necessarily tell us what treatment to use. And I would say it's probably that idiopathic category where we're doing the most biopsies. Those are the patients where we're probably getting tissue the most frequently in order to say, well, we don't know what's causing this, but histopathologically, are we seeing pure fibrosis, mostly inflammation, or a combination of those two? And that's what's guiding that therapy.
That's great help. Thank you. And so this is taking a little bit of a step back, but I realized I forgot to ask you this question. When you have a patient who's coming to you with early fibrosis, when do you decide to do a full serologic workup, do your whole advanced workup versus watchful waiting with CT scan and repeat PFTs?
So this varies amongst pulmonologists, probably varies amongst ILD experts as well. You'll get some slightly different answers here. So I'll just acknowledge that my word is not gospel. I'm just one expert in the field here. So I tend to get a pretty comprehensive serologic workup on the majority of my patients, even if they have relatively stable disease. Now, I do have colleagues who would wait to see if they're going to have progressive disease or wait to get serologies for the time when they're actually going to start therapy to see if that sort of guides therapy. The reason I tend to be more aggressive in terms of my serologic workup is because I think it's valuable to know the potential cause of the interstitial lung disease up front, even if it's not progressive. The reason being is that there are certain antibodies, autoantibodies, for instance, Rho52 or the anti-synthetase antibodies, which are associated with an increased risk of progression or an ILD flare. And it's sometimes nice to know that for prognosis. It's also nice to know that for monitoring of other extrapulmonary signs and symptoms. So if I know a patient has certain anti-synthetase antibodies or myositis associated antibodies, and a patient's like, well, I'm developing this rash that may be related actually to this whole process. And also, if, God forbid, the patient does flare and has an acute exacerbation and they're in the hospital now, I don't need to wait for that workup to come back. I know exactly what they have and how aggressively to treat that. And that can be invaluable life-saving information to have up front, because some of these tests, the myositis antibodies, especially depending on your institution, can sometimes take a few weeks to come back. And that's time you don't have if the patient's having rapidly progressive ILD. So I do think it can be useful information to have up front. So for me, the only patients where I'm not getting a full serologic workup, because it's not inexpensive, are probably my elderly patients who have very mild disease or just a little fibrosis, and I'm not doing anything for them. And we'll have a discussion. I'll say, this is really mild, given your age and all these other things. There's very low likelihood that this is going to be an active autoimmune process, so that we're going to have to treat this. And we probably don't need to spend $900 of your insurance money right now. So let's just hold off. But that's pretty rare for me.